Imagine for a moment that the brain, a universe within our skull, becomes home to visitors it did not invite. Tumors from another part of the body. These are what we call brain metastases. And while the word metastasis may sound ominous, there is hope, guidance, decision, expert teams, and the human will to fight. Solid cancers, for instance, of the lung, breast, or skin, can sometimes send cells that travel via the blood, crossing into the brain and forming new tumors. These secondary brain tumors change everything, such as symptoms, quality of life, and survival. That is why an expert panel convened by the American Society of Clinical Oncology, ASCO, together with the Society for Neuro-Oncology, SNO, and the American Society for Radiation Oncology, ASTRO, came together to review the evidence and produce guidance for treatment. The experts reviewed 32 randomized trials published since 2008, a solid evidence base, and derived how best to treat brain metastasis. They looked at questions such as, when is surgery a good option? When should radiation be used? How does the patient's overall condition and the extent of cancer elsewhere matter? The first key message: if the brain tumor is large and producing pressure or symptoms, the kind that makes a person feel nauseous, confused, or have seizures, then surgery is a reasonable option. More so if the rest of the cancer is under control. The second key point: all patients with symptomatic brain metastasis, that is, symptoms arising from the brain tumor, should receive local therapy. That means treatment directed at the brain lesion itself, either surgery or focused radiation. The decision should not wait until the patient is completely stable systematically. The decision is more nuanced. The panel says don't simply defer treatment just because you're waiting. Instead, a multidisciplinary team must ask, what are the benefits and the risks if we delay any form of treatment? And for the specific scenario of 1 to 4 small unresected metastases in certain tumor types, excluding some like small cell lung cancer, the guideline recommends stereotactic radiosurgery, SRS, alone. It is a non-invasive focused radiation beam that attacks the tumor with precision, sparing more of the healthy brain. If whole brain radiation therapy, WBRT, is used, particularly when there are multiple brain metastases that exist, or when SRS isn't feasible, then techniques such as hippocampal avoidance, sparing the region linked to memory, and memantine, a drug that may protect cognition, should be offered. The goal is to treat the cancer in the brain, but safeguard what matters most, be this memory, identity, or quality of life. But this evidence is not enough. What matters is you, your general health. How many brain metastases do you have? How well is the cancer controlled elsewhere in the body? What are your goals and what are your values? Only when the patient, neurosurgeon, oncologist, radiation oncologist, nurse, and family sit together can the best decision be made. This is why the guideline emphasizes decision-making must be multidisciplinary and individualized. To you or to someone you care for, if the diagnosis is brain metastasis, know this: you are not alone, and there is a roadmap. From the guidelines of ASCO, SNO, and ASTRO, we have reason evidence, and hope. Treatment options do exist. Surgery, focused radiation, whole brain techniques, systemic therapy. These aim in reducing symptoms and to preserve brain function and give you the best possible chance of living well. In the words of an ancient philosopher, the whole is more than the sum of its parts. And here, the whole team, the whole patient, and the whole person matters. And so do you. Thank you for watching and have a blessed